I would like to introduce to you Brandon Hayes-Lattin as our keynote speaker, the Existential 2021 AYA. Dr. Brandon Hayes-Lattin serves as Professor of Medicine and Medical Director in the Division of Hematology and Medical Oncology at the Oregon Health and Science University, Medical Director of the OHSU Knight Center Institute's Adolescent and Young Adult Oncology Program. His clinical background is in the management of hematologic malignancies and the use of hematopoietic stem cell transplantation. As a young adult cancer survivor himself and a physician caring for many young adults with hematologic malignancies, Dr. Hayes-Lattin has taken a leadership role in the development of the discipline of AYA oncology. He has served as the Senior Medical Advisor to the Livestrong Foundation, the Chief Medical Officer for Critical Mass, the Young Adult Cancer Alliance, the inaugural Chair of the AYA Committee for SWOG, participated on the expert advisory panel to the Children's Oncology Group AYA Committee, and was a member of the CDC's Federal Advisory Committee on Breast Cancer in Young Women. I give you Dr. Brandon Hayes-Lattin.
Well, thank you all. I'm really excited for this invitation to talk a little bit about AYA oncology, obviously something that I've been passionate about for a long time. And it was really exciting to hear so many people registering for this symposium. So I want to start by also thanking the Coleman Foundation. I didn't know, since I'm on the West Coast, much about the Coleman Foundation before, but in looking through their materials, found that the Coleman Foundation believes that all patients should have access to high quality services, be engaged in their treatment, and feel empowered to make good decisions about their care. And really, this is exactly what I think of around the discipline of AYA oncology. And hopefully, not only through my talk, but really through the whole agenda of the symposium, you'll really understand what is unique and challenging about these aspects of, delivering high quality service, maintaining engagement, and enabling AYA patient empowerment through their care, because I think it really is different. So I was given a title suggestion of the Existential AYA. I think I might have said that in some other presentation once. And I think this largely stems from the fact that while I feel that AYA oncology has become a true discipline within oncology, that we, for a long time, and I think still are at risk of suffering sort of an existential crisis. So just to remind folks what existential really means, it's really about relating to or affirming its existence. Now, I have been running an AYA program in my institution for quite some time, but I'll tell you, the affirming and reaffirming its existence is an ongoing challenge. And I'll give a little bit of examples of why I think that might be the case. I think it's really important for all of us who do work in AYA oncology to think about the sort of the definitional quote here. So a young artist not knowing how to define himself face an existential crisis. And so I think the knowing how to define ourselves and define this field remains really central to the growth and sustainment of AYA oncology services. And I think this slide really sort of explains why that's the case. This is a snapshot of the prevalence of cancer survivorship. So all individuals in the United States who are alive after the diagnosis of an invasive cancer by age. And what you can see is—
Brandon, excuse me, we're only seeing your first slide. If you're trying to get to the next one.
Oh. Well, let's try this again. I'm glad you stopped me. How about now?
Says Existential AYA. Now we're seeing a chart.
Very good. I'll try this view then.
Survivor.
Okay. So what I was talking about is, maintaining visibility of this AYA field. And this is, I think, the fundamental challenge, which is that if you look at survivors of invasive cancer in the United States, you can see that above the age of 40, there's over 16 million cancer survivors. Whereas the population we're interested in, who have had a diagnosis and are surviving their cancer, is a teeny tiny fraction of that, 678,000, at least in 2009. That, I think, demonstrates why it's important to sort of continue to reaffirm that this is a unique population that deserves unique resources. Now, just for comparison, the number of cancer survivors alive age under 15 is less than 1/10 of the AYA population that we're describing. And yet, when you think about all of the unique resources that go into children's oncology programs for that tiny little sliver of cancer survivorship, you can see that the opportunity is there to do the same in AYA. Just because it's a small population, I think demonstrating the uniqueness of this population will lead to more and more attention and more resources. Did my slides advance?
No.
No. Well, I'm sorry. I, of course, am from a WebEx and Microsoft Teams institution and don't present in this very often. So let me try one more time.
Well, and I apologize, Brandon, because I was having the same issues. So this is something I think, something that we're not used to either from using Zoom.
Yeah, somehow it says my screen share is paused. So I will just try again. Oh. Now it seems that I don't have. All right. Do you see a slide that says Existential AYA at the top, unique cancers?
Yes.
And does it advance?
Yes.
Sweet. All right. So that was a long introduction to say that when I'm asked about the existential component of AYA oncology, I think it's important to know that AYA patients really do exist, even though they may be a small fraction of overall oncology patients. And not only do they exist, but they're uniquely defined by their cancers, by their biology, by their therapies, and by a whole stream of unique issues that this symposium is going to address. So I'm going to hit on those 4 topics briefly over the rest of my talk, starting with the unique AYA cancers. So if you look at the incidence and trends of cancer in the AYA population, meaning those diagnosed with cancer between age 15 and 39, from 1973 to 2015, the rate of AYA cancer has increased substantially. It's increased by almost 30%. Or in absolute terms, the incidence rate has risen from 57 to 74 per 100,000 AYAs per year. So 74 per 100,000 doesn't sound like a lot, but if you multiply that by the 2019 census of people in the United States age 15 to 39, which is almost 110 million, you see that we're now experiencing over 80,000 new cases of AYA cancer a year. Now, you might think of the special cancers that affect this population, and I'm going to go through some of that. But it turns out that the greatest increase in incidence of cancer in AYA is actually a carcinoma, and it's kidney cancer, renal cell carcinoma. So there are some surprises in the incidence and trends. So this is a busy slide. If you start on the left, you'll see a list of the most common diagnoses in various colors by the age at diagnosis. And on the left is males and on the right is females. And what you see is the biggest bars for males and by far the biggest bars for females are actually carcinomas. So we think about some of the unique cancers like germ cell tumor. That's the green, and you can see for males, testicular cancer is quite common. We think about things like soft tissue and bone sarcomas, which are sort of the lighter blue. And we think about lymphomas and leukemias, those are the orange and blue. We think of those as often sort of the prototypic AYA cancers, but I think it's important for those of us who take care of AYA patients, especially those in their 20s and 30s, that actually carcinomas make up the vast majority of AYA patients. You can also see that by the scale of these graphs, that the incidence is quite a bit higher in females than it is in males. And that trend is amplified with older AYA patients. So in the 35 to 39 age range, there's about, in this particular SEER series, there was almost twice as many females as males diagnosed. So to look a little more specifically at males, in that time period from the mid-70s to 2015, the major changes or trends in the demographic have been increases in a variety of cancers. For both males and females, it includes an increase in soft tissue sarcomas, kidney cancer, thyroid carcinomas, colorectal carcinomas, and other GI carcinomas, as well as actually multiple myeloma. And then specific to males, an increase in low-grade astrocytomas, testicular germ cell tumors, head and neck carcinomas, and liver carcinomas. At the same time, there was actually been a substantial decrease in lung for both males and females and in bladder cancer. I highlighted a few of these in bold because those are actually some of the more common histologies of cancer that occur in AYA. And this graph actually shows the same information. It's listing the top 12 sites of cancer in males in the AYA age range. So again, some of the things that you might think of as prototypic actually aren't even in the top 12. But this kind of gives you a sense of some of the changes in incidence over time. Now you'll notice in the middle, there's a big bump in incidence in blue, and that's Kaposi's sarcoma. And many times when we're considering these trends, we discount that bump in Kaposi's sarcoma. And actually, I don't know if you can see my pointer, but along, so almost parallel to that in gray is a bump for non-Hodgkin's lymphoma. And those trends in males are thought largely to be, or almost exclusively in Kaposi's sarcoma, to be attributed to the HIV epidemic of the 80s and 90s. But if you look at some of these other histologies, you can see the trends that I was describing. So the most common tumor of AYAs is germ cell carcinoma or testicular cancer. And you can see that the incidence there in this time period has more than doubled from about 5 per 100,000 to over 10 per 100,000. You can see in some of the other colors, orange is melanoma, there's been an increase, and some of the others that I described. So if you look at that same data source from SEER in females of AYA age range, again, we talked about the increases being the same in males and females for a long list of cancers, but specific to female, there has been an increased incidence in ALL, in non-Hodgkin's lymphoma, in Ewing tumors, in melanoma, and in pancreatic cancer. Again, for both males and females, there's been a decrease in lung cancer, and then specific to females, in a decrease in cervix and uterine cancer, as well as extragonadal germ cell tumors. And here you see that same sort of graph for females. A couple of things to point out here. The total incidence rates are much higher. So for males, we talked about germ cell tumors of the testicle being just over 10 per 100,000. but here you see breast cancer at over 20 per 100,000. So if you're a AYA provider, particularly in the patients in their 20s and 30s, breast cancer is something that you will absolutely be seeing. You can see that there's been a really substantial increase in blue in thyroid carcinoma, where that's approaching breast cancer in terms of common diagnoses for AYA females. In purple, though, you see a decline in cervical and uterine cancer. And if you think about the declines that we've seen for things like cervix cancer and lung cancer, that's largely due to things like vaccinations, screening, and reduction in smoking. So I think it's important to kind of take a look at that snapshot of the cancers that occur in AYA. Again, as we're defining this field, while there are some that are really unique to AYA, there are other things like breast cancer that are quite common in AYA despite being rare in the field of breast cancer. So next, in terms of defining AYA, I'll talk a little bit about biology. So I mentioned before that testicular cancer is the most common cancer of AYAs in their 20s and 30s. This is looking at it a different way. This is the incidence of testicular cancer in all males of all ages. And what you see is if you're a male who's diagnosed with testicular cancer, the vast majority are in this AYA age range, right? So this sort of describes that that there is something about the biology of testicular cancer that is unique in onset in the AYA age range and actually drops off substantially above the AYA age range, suggesting that the biology that leads to this incidence is specific. There are other sort of epidemiological trends that also point to the likelihood of unique biology. This is a curve of the incidence of melanoma in males. And if you look at the AYA age range from 15 to 39, what you find is that in the blue colors and the black, the incidence of melanoma in the extremities and the head and neck is actually lower than the incidence of melanoma on the trunk. Well, if you think about our sort of common understanding of the pathophysiology of melanoma, it's mostly attributed to repeated and prolonged UV exposure. And the places that we typically get that UV exposure from the sun are our head and neck and extremities. So to see an incidence almost double of truncal melanomas in AYAs suggests that there's something different about the biology that leads to those melanomas in younger patients besides just sun exposure. We'll talk a little bit about breast cancer. So unlike almost all diseases in medicine, it turns out that females who are diagnosed with breast cancer under the age of 40 actually have a worse prognosis than patients who are diagnosed older. And again, that's not a common phenomenon in medicine, suggesting there's likely unique biology. You can see that trend in lower 5-year survivals in breast cancer is true whether a woman presents with localized disease just in the breast, regional disease involving the lymph nodes, or distant metastatic disease. It also turns out that younger women with breast cancer are more likely to present with regional or distant disease than older women. So again, this suggests different biology. Another epidemiological clue that would suggest different biology is just to look at the incidence curves of breast cancer as I showed you for testicular cancer. And one of the things that was actually described in the 40s and 50s by a Dr. Clemison was that the incidence curve actually has an appearance of being bimodal. So you can see that as opposed to sort of the incidence going up after age 20 and then falling after age 80, that there's actually a dip in the middle. There's kind of two peaks. Well, it turns out that that is an epidemiological clue of biology. And if you take that same data and plot it by whether the breast cancer tumors were positive or negative for the estrogen receptor, what you find is ER negative tumors have an incidence that is has its own peak about 20 years earlier than ER positive breast cancer. And that really the overlying incidence that we see on the left is kind of overlapping incidence curves for two different kinds of cancer, for ER negative and ER positive disease. Well, since that time, we've learned a lot more about breast cancer. Breast cancer specialists will often describe various histologies of breast cancer. There's a particular type of breast cancer where the transformation event that causes cancer likely happens in what's called the basal cells or basal cell compartment of the breast tissue that leads to cancers that are termed basal-like, that tend to be negative for hormone receptors like estrogen, and also negative for HER2 expression. Whereas if the transformation event that leads to cancer occurs in the luminal cell compartment of breast tissue, you see either HER2 expressing tumors or hormone receptor positive luminal A and luminal B subtypes. And it turns out that the incidence of this, it differs by advancing age. So if we take a look at this same sort of biology and apply it to those incidence curves, what you see on the left is, again, this bimodal distribution where breast cancer is not all the same, and there is sort of a younger peaking breast cancer of basal-like tumors and quote unquote older breast cancer subtype of non-basal-like. Now, clearly it's not all or nothing, but you can see the trend is really significant, with the peak being approximately 20 to 30 years different. And the graph on the right shows that not only does the incidence of these different subtypes of breast cancer change, but the prognosis changes as well. So if you look at the hazard rate for dying of breast cancer, you can see that the younger basal-like subtypes has a significantly increased hazard ratio for death early in the years after diagnosis than the older non-basal-like breast cancer subset. So this is some of the work in AYA oncology that has looked at these unique cancers and some of the unique epidemiology and led to discovery of biological differences. Now, this is not unique. This is non-Hodgkin's lymphoma, and you can see this has been long also known to have bimodal age distribution. Finally, in terms of biology, I'll talk a little bit about leukemia. This graph, the different colors show different subtypes of leukemia: acute myeloid or acute lymphoid leukemia, lymphoblastic leukemia, or chronic leukemias. And what you see at age of diagnosis over time is that the colors change, and that young children who are diagnosed with leukemia, the majority are diagnosed with ALL, whereas above age 40, ALL makes up a tiny fraction of leukemia diagnoses compared to chronic lymphocytic leukemia, chronic myeloid leukemia, or even AML. So that, again, clue to different biology. If we look specifically at ALL, what you see is that the age of diagnosis of ALL has historically led to very dramatic differences in survival rates. So at the top in green, if you were age less than 5 diagnosed with ALL, you could see 10 and 20-year survivals of 60%. Whereas if you were age 15 in blue, those survival rates were more like 30%. So really substantial differences in expected survival rate for ALL based on the age of diagnosis. And so again, if you take a look at those as potential clues for differences in biology, you get to data like this. This shows one way to look at the biology of ALL, which is simply to look at the chromosomes within the cancer cells and whether we see translocations or other breakages in those chromosomes. And oftentimes we do, and you can see the colors here represent a variety of those known mutations. But you can see that the colors change substantially by age. So below age 15, you see things like in orange, high hyperdiploidy, or you can see the translocation between chromosome 12 and 21, which involves a RUNX1 protein. Those tend to be better prognosis ALL cases, regardless of age, but you can see they're selected for in the younger patients. Whereas in older patients, you begin to see the purple, which is translocation 922, otherwise known as the Philadelphia chromosome, which historically has had been a marker of aggressive disease and poorer prognosis. Same thing with in the dark blue, the translocation 411, the MLL translocation has been associated with poor prognosis, and you can see that that dark blue at the bottom tends to be more frequent in the AYA population. And maybe most importantly from this graph, if you simply were looking at chromosomes, you see the light blue, which is other, which means that there's mutations or abnormalities in the leukemia cells that aren't discoverable or explained simply by looking at these chromosomes. And you can see that that other mixed bag category is actually the most common in the AYA population, meaning that we really need to dig in and understand that biology. And that work is continued with discovery of some ALL that does not have the Philadelphia chromosome translocation, but has gene expression profiling and protein expression profiling that is extremely similar, something that's called a Philadelphia-like ALL that is a known biological distinctive feature in many AYA ALL cases. So we talked about differences in cancers of AYA. We talked a little bit about the biology of AYA. What do we know about treating AYA patients? So many years ago, data was presented looking at Ewing sarcoma among 3 different clinical trials where patients, including patients aged 15 to 20, were all sort of treated in a uniform fashion on these clinical trials. And what we found, what was presented was that patients on these trials who received their care at pediatric institutions had a significantly better survival than patients also 15 to 20 who were treated in an adult medical institution. And you can see here that the event-free survival, meaning no relapse, no death, was almost double, approximately 50% versus 25% in a pediatric versus an adult institution. And this, I think, was one of the early examples of showing how these differences in survival rates in the AYA population might really lead to clues about the treatment setting and the type of treatment used. I believe Dr. Stock is in this symposium, so she can answer questions about all of the data of hers I'm going to present here. But one of the seminal things in AYA Oncology was her presentation of a similar finding in pediatric versus adult ALL, in this case, age 16 to 20 at diagnosis. But this is not a separation per se based on a pediatric versus an adult institution. This is based on the clinical trial. And you can see that CCG, or now called COG, a pediatric clinical trial, led to 7-year event-free survivals of 63% compared to a contemporary adult clinical trial also treating 16 to 20-year-olds where the 7-year event-free survival is only 34%. And so Dr. Stock and many others started looking at, well, what's different between these chemotherapy regimens? Why might we see such a difference in the same age patients with the same disease, but on different trials? And this is a busy graph, but it's really meant to just illustrate that there are very differences in the drugs and the doses of drugs between these pediatric protocols and adult protocols, leading to the hypothesis that perhaps it's actually the chemotherapy that's leading to some or most of this difference. That led to the development of an adult cooperative group trial that essentially took an arm of the pediatric regimen, but applied it to patients aged 16 to 39, with the goal of seeing if that would improve survival outcomes in AYAs with ALL, whether or not there were differences in either the efficacy or the toxicity of this regimen in patients up to age 39. And also, since the regimens were new and complicated for many adult oncologists, whether or not an adult medical oncologist, what their rates of adherence to the regimen would be. There were also components of this study that address things like drug delivery, which you can imagine might be a consequence of the provider, who, based on perceived toxicity, may hold or omit doses, but also may be a marker of a patient and their ability to adhere to therapy. Well, this trial has been presented by Dr. Stock, and the event-free survivals reported here show that compared to those historic controls I showed before, survival appears to be significantly better. So again, I showed you before a 7-year event-free survival of only 34%, whereas here we're seeing closer to 50% using a pediatric regimen of treating AYA ALL. So again, the treatment of pediatric cancers is probably a mixture of, well, what are we actually treating the patient with, and who's delivering the therapy in what setting? This is a study I like to show that looked at a cohort of patients in the pediatric world who were treated as, their cancer was treated as part of a clinical trial, versus what's called a matched cohort of patients that appeared to be similar in age and diagnosis, but were not treated with a clinical trial. They were treated with standard of care therapy. And what you can see in red is that the survivals are actually better in these pediatric patients who are treated on clinical trials. Now, you're going to have a whole lecture from Dr. Roth about clinical trial participation, but needless to say, this has been a major deficit, a major issue in AYA oncology, is how do we get more patients on clinical trials? And then finally, there are challenges around sort of the lifestyle of AYA and where these patients present. The National Cancer Database took a look at ALL patients under age 40, a very large cohort of 22,000 patients, and found that if you had ALL under age 40, your survival was worse if you lived more than 50 miles from the ALL treatment center. There were other factors, like if you were non-white, if you had either governmental insurance or no insurance, if your income was less than $63,000 a year. Those were some of the factors. But when you adjust for those covariates, distance over 50 miles still led to lower survival in ALL. What's important is that was true for ALL, but not for AML. So ALL is often fairly intensive, but often outpatient therapy, whereas AML is often a leukemia that we treat with repeated hospitalizations where distance may not matter. So there's probably a lot of factors in delivering therapy that we can investigate and improve on to help the survival of AYA cancers. Finally, I have just a few slides about unique AYA issues. Really, this is what this symposium's about, so I'm just going to touch on some of the unique issues. But needless to say, AYA is a wide age range. and you see every type of patient in this age range. Let me just talk a little bit about some of these unique issues. I still think it's really important to take a big step back and think about what is the developmental stage of patients in AYA. And for the most part, if you look at sort of Erik Erikson's classic stages, we're talking about stages 5 and 6 here, where the sort of, again, existential crisis for AYA is in either ego identity and role confusion, or in intimacy versus isolation. You can see that the chief virtue is often fidelity and love. The key relationship is often peers and friends. And that's sort of the context for which we're treating AYA patients. I was asked once to give a presentation in Europe about why did the United States pick such a wide age range of 15 and 39. And my answer was, well, the developmental milestones are actually quite fuzzy, but this whole age range kind of captures a key time in most patients where they're developing their identity, they're establishing their lifelong habits, and they're forging the relationships that will enable a long and meaningful life. But it's also the time of sex, drugs, and rock and roll. So you'll hear more about fertility in this symposium, but needless to say that across the world, whether you live in a place where the average number of births per woman is only 1.3 or 5.1, 15 to 40 kind of defines the age of fertility. In terms of drugs, alcohol, and cigarettes, you can see that above age 15 is where these issues come to raise. And actually they drop off after age 40, not just in alcohol use, but in binge or heavy alcohol use and in cigarette smoking. And even rock and roll, it turns out rock and roll is pretty popular across all ages, but not so much with hip hop. Hip hop is a very AYA music genre. So, you know, it's not really a joke when we talk about understanding sex, drugs, and rock and roll as part of taking care of AYAs. Insurance concerns are a major obstacle for many AYAs. And I really like this study from the AYA Hope study, where they asked a bunch of patients, were there tests that your team prescribed that your insurance didn't cover? And about 20% said, yeah, my team said I should have a certain test, but it was not covered by whatever insurance it was. And it turns out that 80% of those AYAs got that test anyway, as you can expect most people would if your team is recommending it. This kind of leads not just to sort of the overall concern of do you have insurance or not, but the risk of financial toxicity that is really important for AYAs. And then finally in the symposium, you'll hear much more about fertility, but I think that this is a good example of the type of fertility concerns that we might see in young adult patients. This is from a young woman's breast cancer study where in a survey of 600 patients under the age of 40 with stage 1 to 3 breast cancer that was expressing hormone receptors, meaning that they were eligible for hormonal adjuvant therapy, a third of these patients said that future fertility affected their decision of whether or not to take that hormonal therapy. And of those patients who it did affect their decision, 40% either did not start hormones or were not persistent with their hormones over the entire course of therapy. And of those who said that endocrine therapy affected their decision, 2/3 reported either pregnancy or pregnancy attempt. So fertility concern directly impacting therapy choice. So that's what I brought for you. I think the existential AYA issues are that AYA patients, they do exist, and they are uniquely defined by their cancers, by their biology, by their therapy, and by these AYA issues. And with that, I thank you very much and be happy to take any questions.
That was fabulous, Dr. Brandon. I'm trying to talk too much here. No, you really nailed it. You nailed it on the uniqueness in regards to biology, in regards to treatment, and who AYAs are. And that is why we're here, because this population is so unique, and we need to adapt, obviously, not only our treatment, but our care and how we approach discussions, how we approach fertility, how we approach their lives in this unique stage between the ages of 15 and 39. Absolutely fantastic. Thank you. So I do see a question in the chat, and I'm wondering if you could answer this. Why such a sharp increase in thyroid cancer for females?
Yeah, I don't know that we really know the answer to that. I think for some cancers, including an AYA, there have been trends for increased diagnoses of cancers, not necessarily increase of underlying incidence of cancer. So an extreme example of that in the adult world is prostate cancer, where it's argued that there are many men who may be diagnosed with prostate cancer, but it's not going to actually impact their livelihood, and we sort of overdiagnose. And those same kind of arguments do sometimes get made with thyroid cancer, that we are more aggressive about looking for and working up thyroid nodules that do turn out to be cancers, but they may or may not be impactful. However, there may be other reasons that there are true increases in thyroid cancer, and I think the jury's still out on that.
Excellent. On that same line, I found it interesting in your melanoma presentation that there is data that shows that AYAs get melanoma more on their trunk. That was fascinating to me. Do you have any thoughts on that? Why is that incident? I know you had said that that's some of their uniqueness with their biology, but do you have any thoughts on that?
Yeah, so I'm actually not a melanoma specialist, but I can send around a reference. The NCI actually published a report of some of the unique biology of various cancers, including breast cancer and ALL, and there's a section on melanoma as well. These are often associated with specific tumor biology that is different. That's probably true whether you get a truncal melanoma at any age, but so it doesn't. I don't necessarily know the reason that it is more selected in young people, but there is certainly unique biology to truncal melanomas.
Excellent. Well, thank you so much.
Yeah, thank you all.
Really appreciate you, joining us today and setting the tone
for slides.
We feel that. I feel that. Well, thank you.